All right, so I am going to switch gears and try to catch up a little time here. And we are going to talk about safety. So, overview. Herpes zoster, shingles. Can't watch TV without being frightened of getting shingles. It's a disease that is complex and fascinating. It is increasing epidemiologically all over the world. And it's not just a recognition bias. There is an increased rate of zoster that cannot be explained. Obviously, the risk factors that we're aware of are age and immunosuppressive states. The question is, how much are we contributing to this, and what is the significance of it, and does this give us impotence to try to intervene with preventive strategies such as vaccine? So this was a study that actually looked across all diseases. And another study by Jeff Curtis. I have so many Jeff Curtis abstracts here today because they've done so much. So in general, in the rate of shingles per 1,000 patients per year, there's about 3 patients, 3 people will get shingles. Now, this is not age adjusted, this is general population. If you look at older people, it's going to be much higher. If you look at younger people, it's much lower, but not 0. If we look at all of the disease states ranging from lupus, IBD, RA, et cetera, compared to the healthy group here, you can see that there is a palpable increase of shingles. Now, the benchmarks, the upper limits of this, the Wegener's etanercept study from several years ago showed rates of about 35 per 1,000 per year. And drugs, the tofacitinib trials have shown rates of about 40 per 1,000 per year. So we are into this, and we are have a population that is prone to this. Okay, so what is the big deal with this? First of all, this is a painful, ignominious condition to have, and the major complication, as you're all aware, is postherpetic neuralgia. Yet, there is another dimension to zoster that is just now being appreciated, not so much in the rheumatology community, but in the neuroimmunology and neurovirology community. And I show you just the most recent study of 4 well-designed epidemiologic investigations demonstrating that zoster, shingles, is a risk factor for stroke. And this occurs particularly in the weeks to months following stroke. And this doesn't have it's independent of whether this is herpes zoster ophthalmicus or you have it on a lumbar dermatome. There are a lot of data, whether it's influenced or not influenced by antiviral therapy, but I think that people are paying attention to this. Zoster varicella is a known risk factor for stroke in children, and as many of you are well aware. And the science behind this is fascinating, and Dawn Gilden, the University of Colorado, has demonstrated that varicella is the only virus that actually lives and replicates in cerebral arteries. And he'll be coming next year to our Biologics Summit, so it's going to be great. So I'm throwing this in as kind of an added notion here. And if this holds true and you read about this, will this influence the way that we influence our practice about vis-a-vis vaccination? So first let's get a vote right now, and then I want to throw this open to the panel here to see what's going on. I tend to agree with this. So what do people think of this?
So those large Medicare databases should be able to really tease out reported cases of zoster and stroke and see whether if that can be replicated or confirmed. I think this is a game breaker, right? This is everybody over 60. You really would work them hard, especially if they have cardiovascular risk factors. You would really work them hard to get the vaccine.
There's also some inferential data in these epi studies, which I don't have time to go into, is that early and aggressive therapy helps reduce that risk of stroke as well. And you know, the treatment recommendations for shingles are kind of, you know, if it's mild attack, you know, you could, no, I don't think there's any room for not treating this. Particularly these drugs have virtually no risks whatsoever.
But what is actually the usual scenario? Onset of symptoms, and then when might a stroke occur?
Delayed, weeks to months, and the risk goes down over that year following this. So it's that we've known for years the syndrome of herpes zoster ophthalmicus and delayed hemiplegia, 6 to 12 weeks after having shingles on this side, develop a big stroke, motor stroke on the other side, and it was due to centralized spread of zoster from the geniculate ganglion to the carotid to the base of the brain. So I throw this out as just kind of an interesting thing, and you're going to hear a lot more about that. Come to the summit, we're going to be talking about it.
So would you delay treatment for someone to get their vaccine approved? And
Well, I mean, I think
Because, I mean,
that's the discussion that requires hand waving and beer drinking to answer that. So we got to move on to this. Recurrent infections among patients on TNFs. TNFs are associated with serious infectious episodes. There have been scores of randomized controlled trials that show that compared to placebo, that they increase serious infection risk. When you compare it to non-biologic DMARDs, not so much, but still data in that direction. But the question here is, what about if you have a serious infectious episode and you're on these drugs, what happens to you again? What's your risk for a second one? Because that's really, you know, how we're going to do this. And this is a study, a very complex study, again, by Jeff Curtis's group. And I actually sent him an email the other day, and he sent me the details of this. But I'm just going to give you the punchlines of this. So the rates of a second serious infectious episode in the year to 18 months after having one serious infectious episode, based upon whether the patient was on any of these biologics, and most of them were moving forward on the same drugs, showed surprisingly that if you were on non-biologic DMARDs and had a serious infectious episode, you have a 20 out of 100 patient year risk of a second in that year following. And you know, numerically, certainly less and not intuitively greater by being on a TNF. The highest would be that if you were on a non-TNF biologic, this is really a dramatic rate. We're used to looking at rates of SIEs of 2 to 5 to 6 out of 100. So, you know, what does this actually mean to us? I think I have a slide here. I don't have the slide. So I was going to show the rabbit risk score. So the rabbit risk, actually, I have it.
But can I set you up,
Yes.
though? Because I think that there's a key principle here that I've pondered for many years, which is rheumatoid arthritis patients get more infections. They actually get more serious infections. If you get a drug approved, you then closely watch patients that are treated with that drug that have rheumatoid arthritis, and then you have these numbers derived. But really, the central question is, do people with worse control of their disease, more disease activity in rheumatoid arthritis, is their immune system more deranged, and that's actually the greatest risk of serious infection? Or is it actually your greater risk because of the immunosuppressive qualities of the medication? So is it the disease or is it the treatment that really lends to the greatest difficulty? And I think that actually is set up for the rabbit registry and what they found.
And I'll come back to that. I think that's a really important point. And it's obviously difficult to tease out in large registries where you just can't immediately do a sensitivity analysis to control for these things. But steroids are always big.
Serious, I don't know how to make sense of this. If I have a patient who has a serious infection, I think we would all treat that patient incredibly carefully going forward. But if I would still want to manage their rheumatoid arthritis, getting back to Greg's question. So I know we sometimes stop biologics if they have a serious infection or recurrent serious infection. So I'm not sure how to, this is fascinating, but I'm not sure how to apply it in my real life.
I'd like to know what the DAS scores are for each of these groups at the time that they have their event.
Yeah, well,
These are
this is a
registry
registry data, and you
How
don't have
many
it.
are smokers? In my practice, if they smoke, it's infection after infection after infection.
All right, I'm going to come back to these risks for infection in a minute. You've got to bear with me here, all right, because we've got to go through this. All right, the third topic is reactivation of hepatitis B. As most of you know, this is a pet topic of mine, and there is a national move afoot to prevent reactivation of hepatitis B. And I know it is a rare event, but it is serious and potentially life-threatening. And all data suggests that none of us who take care of autoinflammatory and autoimmune disease do a great job of routinely screening for hepatitis B beforehand, but we're getting better. We're getting better. So we know that TNF inhibitors carry a class warning for hepatitis B reactivation, but we don't know much about the follow-on drugs. And there's reasons for that, because none of these drugs come through clinical trials anymore. Everybody's screened for hepatitis B.
Right.
So they arrive on the market, and you have no data. And that is a bad situation to get in. So this group looked at patients on tocilizumab and abatacept who had varying degrees of hepatitis B that we classify as one, they were called chronic inactive carriers. In the old days, for all the old people here like me, these were called healthy carriers. There's no such thing as a healthy carrier of hepatitis B. This is the inactive carrier state, low viral load, surface antigen positive. Far more complex and nuanced is the isolated anti-core antibody. You can go to countries in Asia where half the population carries this. So this is really a significant thing. Once you have hepatitis B, you always carry hepatitis B. It exists in these covalent episomes within the hepatocyte, so you never eject the virus. And you're always potentially susceptible to reactivation. So they looked at patients on ABA and TOSI who happened to be in these categories. And they found 17 of them out of a group of 125 patients who were on these drugs. 16 of them had so-called occult hepatitis B, being only anti-core positive, and 2 patients were inactive carriers. The bottom line of this is that there was one inactive carrier that blipped their HBV DNA, but nothing bad happened. They intervened with antiviral therapy, and these patients, the standard of care is that patients who are surface antigen positive should always, always, always be on an antiviral therapy. The thing that I was interested over here is actually the group with occult hepatitis B, because we have virtually no data on this. And out of these 17 patients, there was no reactivation, no retroseroconversion. And so in that group of people, this is a little bit of data to suggest that at least the risk is maybe modest. In our algorithm to manage patients with occult hepatitis B, even for patients with TNF inhibitors, we merely follow these people. We check them for hepatitis B DNA at baseline. We check it again at about 3 months, and if they're stable, we just monitor them, their liver enzymes. This group with chronic, who are surface antigen positive, they're all on treatment, and probably for life if you're on biologic therapy. So, question, this is from a review from Demetrius Vasilopoulos and myself in Nature Reviews of Rheumatology in 2012 of how we view the worst risks are surface antigen positive, the least risks are those that are core antibody positive and surface antibody positive, and this is a very gray zone over here. So we're adding a little bit of data to tell us what's going on. The other hepatitis B abstract that I picked was rituximab. So as everybody knows, is that in October of 2013, this is the only biologic, the newer biologic, has a black box warning for hepatitis B. And it's not an option. You've got to screen for hepatitis B before rituximab. They should have already been screened because they're on methotrexate and TNF inhibitors, but it gives us a good chance to catch up. The real question is, what about people who are just anti-core? Surface antigen positive, they can be treated and they can get rituximab. We know this from the cryo literature. Well, this abstract looked at a large group of patients who were anti-core positive who had received rituximab for rheumatoid. Now, to set the stage, whether you know this or not, in the lymphoma literature, rituximab plus combination chemotherapy like R-CHOP, even if you're anti-core positive, that regimen reactivates hepatitis B about 20% of the time. So it's serious. But practical experience of people who use rituximab, we've not seen that. And so this looked at a large group of people. Most of them were surface antibody positive. They were not antivirally prophylaxed. They got 3 cycles median of rituximab. And out of this group, there were only, they followed quantitative surface antibody levels. 2 of them fell below 10 IUs, which is the protective level of anti-surface antibody. But when they looked at what happened, only a single patient even minusculely blipped to 44 IU their HBV DNA. This is trivial. This goes on all the time in people who have this. One single patient had an ALT flare, but they did not believe this was related to HBV activation because they remained negative. So the conclusion at this juncture, looking at a large number of patients who are anti-core, going on to rituximab, is that the risk must be, there's no confidence intervals given here for safety, must be very low. So this is an area of controversy. The French investigators right now have said that if you have anti-core positive and you're going to give rituximab, you should go on antiviral therapy. Others have said you can watch and wait. So the question is, will this influence your practice for selection of biologics and their management at the present time? So respond to this. It's a complex area. Anybody want to throw out questions, comments?
What would be the duration of treatment for antivirals in these patients?
All of our data, and this expresses the uncleared nature of these data, and I empathize with everyone. Most of our data on hepatitis B management and with immunosuppressive comes from oncology, and they're just different from us. You get your chemotherapy and then you're done. You don't go on lifelong therapy. And their practice is after induction chemotherapy and completing a course of chemotherapy, they generally wait about 6 to 9 months and then they stop. Some people have suggested that if you're on antiviral therapy, after 9 months you could conceivably stop it. For surface antigen positive, we believe that that is indication for lifelong therapy, which is a trend in hepatitis B anyway. Or these agents have no toxicity to speak of, and they're well tolerated. For the core patients, if you want to adopt the kind of the French mode of treating for a while and nothing happens, 6 to 9 months, it could probably be stopped. It's a work in progress. This is an interesting study. So another comorbidity, and here is the rabbit risk score. So I just sent a note to one of the local rheumatologists on a patient that came up, and I put the rabbit risk score in the notes. I'm waiting to get some feedback here. So this is readily available. Google rabbit risk score, and this gives you based on age, disability, previous history of serious infection, COPD or chronic lung disease, okay? Chronic renal disease. How many DMARDs, how much steroids, and are you on a TNF inhibitor? And this was given to me by Jack Cush, 47-year-old woman, no comorbidities, 2 prior DMARDs, HAC 0.5, methotrexate, prednisone 10. Rabbit risk score comes out of 1.4%. If she was on a TNF inhibitor, 2.6%. This patient, on the other hand, is a 62-year-old woman with COPD who had pneumonia, just like the patient you were talking about, William. Failing multiple DMARDs in biologics, has active disease, has more disability, and is on 15 of prednisone. Rabbit risk score, 45%. This is, natural signs of danger, and this is important to note. So another comorbidity that's not included in the rabbit risk score, and I suspect is rapidly working its way in because this comes from the same German group, was looking at their rabbit population with about 240 patients with congestive heart failure. Now this is looking at comorbidities in the CHF patients. And so, yeah, there are a lot of things in here that make you more vulnerable to infections. This is common sense, and this is a different group of people by everything from age to other comorbidities. But the data are rather striking as what the influence is. When you compared the CHF group to the other 9,700 patients who didn't have this, the rates of infection climb significantly, 16 to 100 patient out of 100 patient years. This is quite higher. When they looked at the higher incidence of pneumonia, it was particularly high, up to 30% of these serious infections, and 20% of these serious infections were sepsis. Obviously, this had a major weight not only on the nature of the infection, but the mortality from these infections. And when you compared the overall mortality in the group, 24 per 1,000 patient year for 4 per 1,000 patient year, it's palpably different. So this is not in the rabbit risk score. I know that we all are sensitized to CHF because of data with biologics, but the conclusion of this is that overall there's a hazard ratio of 9.3 to at least one non-fatal SIE in the follow-up period. And is this going to influence my patient in selection of further therapy? So can we vote on this? While we're voting for this, so how does this data strike you? Is this as expected, or just why hasn't this been plumbed out before? Or
I think it's been underappreciated recently. I mean, we know about the risk of cardiovascular disease, and people mostly think about atherosclerosis, but this actually may be not completely the same syndrome. There's an association with the shared epitope in CHF, and this may relate to a disease where, in fact, immune complexes are directly affecting the myocardium. So we don't understand enough about the pathogenesis, but it may really be intertwined in what drives seropositive RA in general. And the question is what interventions you may be able to have. Some versus others may be more effective, but there really is very little known at this point.
patient with well-controlled congestive failure on some afterload reduction, but with active disease, what do you gravitate to in your practice to treat that rheumatoid?
Well, I was just thinking, I gravitate away from the TNF antagonists, of course. They're increase the progression of congestive heart failure, and so that's not the winning strategy. And so then you move on to your other agents, which are there's four other agents that probably come to mind: abatacept, rituximab, tofacitinib, and tocilizumab. And then, like I said, in my practice, more and more, just like congestive heart failure, I think this is what it's telling us, is that the comorbidities are driving our decision making. If they have a history of diverticulitis, tocilizumab is off the table. If they had a recent episode of zoster, or if they've had shingles in the last 5 years, am I going to reach for the tofacitinib so quickly? So I don't know. What about you, Elaine?
Yeah, I agree. I mean, I think we're lucky to have all these in our toolkits now, but clearly things are influencing how we're making our decision. And there's triple therapy. There's
Absolutely.
a big, great debate,
is,
I've shouldn't use the word resorted, but I might think about that again.
Right.
All right, a couple quickies here. CRP and infection. I just thought that this was just this is kind of a biologic lesson for us. They looked at patients on the only approved anti-IL-6 receptor inhibitor and asked the question, in the face of documented infection, what is the influence of this on CRP? And we're looking at 10 milligrams per liter, so we're talking, a very modest CRP level. And it reminds us that in bronchitis, a disease where you don't expect a lot of CRP, very low levels, but even in people with well-documented pneumonia, looking at the ranges of this, you can get serious infectious episodes with very, very normal-looking CRPs, and it's just kind of a wake-up call for us to, this is not the final arbiter. So anybody want to throw in on procalcitonin on CRP? Anybody know any data on that?
No.
Me neither. I looked for it. I can't find it, but I don't know if it's under the same promoter. All right. So those are actually all my safety slides. I don't have anything on this. Anybody would like to throw out any questions or comments for the group on anything that we've done before we take our break? Dave.
Has anybody had a zoster occur after vaccination when the patient's inadvertently on an anti-TNF?
I'll address that because we did this study over 3 years ago. Jack Cush and Bingham and I, we sent this shout out to clinical rheumatologists, and they gave us anecdotes of 300 patients who had been on biologics who had, quote, inadvertently got Zostavax, and they described no serious episodes or complications. And then Jeff Curtis looked in his Jeff Curtis way of looking at Medicare database. He found over 600 patients on active biologics by treatment code who had been given Zostavax, and then looked in the next 42 days to see if they had been treated for shingles. And there was no episode of shingles in the 42 days, and B, as they followed that group out, they actually had protection compared to the non-vaccinated group. So we're moving towards hints that vaccine is probably okay in this group, but nobody is blinking and making a recommendation, and there's a safety trial that's on the drawing boards right now that we're looking at.
Could I go ahead and give the Zostavax based on?
All right. Good man. All right, we'll have to collect that data.
In our-
Well, just collect how many people are safe.
Publish a series.
Yeah, it's great, time after time. Any other comments? All right, we're going to take a break right now, a little coffee, then we're going to come back and switch gears.